Welcome, everyone. Hope you can hear me. Thank you for joining us today. We're so excited for this important conversation around femtech and fertility, and we look forward to everyone's questions. Before we get into the conversation, I'd like to just do a few brief introductions. I'm Diana Messione-Jackson, the co-founder of KORÄ, and I'm so happy to be moderating this conversation today with KLU and Pelex. At KORÄ, we are building a community-based, data-driven, action-oriented platform to empower women embarking on or undergoing fertility treatment to navigate reproductive health and wellness with confidence and control. The idea for KORÄ was born from our own personal struggles trying to conceive through IVF. Like so many women, we've been through so many lows in our journeys to conceive, unsuccessful cycles, miscarriages, pregnancy loss, and more. We found there was no single trusted source for information and no easy way to connect with other women at the same stage, and that's what we set out to fix. We believe in the possibility and promise of a better experience, one that is rooted in data and research, as well as human connections to other women with similar experiences, as well as a broader community of experts that are part of our ecosystem. Our goal is for our community to understand their options, have the information they need to make proactive and informed decisions, and feel supported. Today, we have the pleasure of speaking to two outstanding co-hosts, Dr. Lynae Brayboy of the KLU app and Dr. Erin Wolf of Pelex. I certainly won't do them justice in these brief introductions, but here goes. Dr. Brayboy is the Chief Medical Officer at the Women's Health and Period Tracking app KLU. She is a trained OBGYN and a specialist in reproductive endocrinology and infertility. At KLU, Dr. Brayboy provides a clinical perspective on how the app can address the unmet needs of women and people with cycles and delivers critical research that will assist healthcare providers. She believes in anyone with a cycle getting the information they need so that they can feel prepared when having conversations and creating a plan of care with their providers. Dr. Erin Wolf, the founder of Pelex, is a reproductive endocrinologist with 18 years of clinical and research experience on reproductive health. She founded Pelex as a physician concierge and consultant to help families on their fertility journeys and strongly believes in early intervention and better screening. Pelex is now an online telehealth platform that makes fertility care more accessible and easier to initiate. Before we begin, I just have a few quick notes on the flow of the discussion. We'll spend the first 30 to 40 minutes for a moderated discussion on what every woman and person with a cycle should know as they begin their reproductive and fertility journeys. And then we'll open it up at the end to your questions for the rest of the hour. So please feel free to write in your questions at any time during the discussion, and I'll invite you to say hello now in the chat. Please tell us where you're joining from and where you are on your fertility journey. Okay, with all of that, let's get started. So let's begin with a really simple question just to break it down. Why should we track our menstrual cycles? Dr. Brayboy, let's start with you.
Yeah, so a lot of people think that, why does it matter? But really, when you're interacting with a healthcare provider and you're interested in getting pregnant, it's important to know, do you have typical predictable menstrual cycles? And a lot of people can't answer that question. So a lot of patients, they'll come into the office, they'll speak with an infertility specialist or with their OBGYN, and the first thing we'll ask is, okay, tell me about your menstrual cycles. And a lot of people have a real hard time actually remembering, when did their first menstrual cycle start? How often do their cycles come? How long do you bleed? And those are very simple questions that can tell us a lot, actually. So it's really important, and one of the things you can do at KLU is to really track your menstrual cycles and know your history. You can also observe if there have been any changes. So if you, for 10 years had let's say 30-day cycles, and you bled for 5 days, and you had premenstrual syndrome, and then all of a sudden your periods change, all of a sudden they get lighter, all of a sudden the cycle gets shorter, that is a clue for your physician that something might be going on, or perhaps you start to have really heavy periods, or you're having extreme pain with periods, what we call in medicine dysmenorrhea, painful periods. If that starts happening and that gets progressively worse, that can indicate something else that could affect your fertility. So period tracking is really important. It's your own medical record. It's your way of communicating, this is what's happening with my body. A lot of people think of the period as a vital sign. So if you are having a predictable, regular, normal menstrual cycle, that means that a lot of things are working together. That means that a part of your brain called the hypothalamus is interacting with the pituitary, which is interacting with the ovary, which is allowing you to menstruate because the uterine lining is able to shed. And that is something that you need to keep tabs on. And when I was, let's say 9, when I got my period, I wish that I had something that I could have been actually tracking how it's changed over time. And so that's why period tracking is really important.
I completely agree with you. And so with all of that said, when is a good time to start? I think many people just start when, say, they want to get pregnant, but when would be the ideal time to start so you really do have a great tracking of your reproductive health?
I think it's best to start as soon as you're thinking of having a child, or even before. I think period tracking is for the entire reproductive lifespan. I wish that I had started tracking when I had my first menses at 9. My daughter tracks her period. I think that having more information is always better. And then you can look at your own patterns. But if you're specifically trying to conceive, start right away, because that gives you an indication of what's happening. And a lot of people will have been on let's say hormonal birth control for a very long time, and they may not remember what their menses were like before they started the hormonal birth control. So once you come off it while you're trying to get pregnant, it's really good to start saying, okay, I've had 5 menses, or I've had 5 periods since I stopped my hormonal birth control. And that's important for the physician to know about.
That's a great segue into our next question. So I know there are so many misconceptions around birth control use and fertility. Is there any impact on fertility from long-term birth control use? And the second question is, what should women expect when they decide to go off birth control? Dr. Wolf, do you want to take this one?
Sure. Thanks. So birth control pills and how they affect the menstrual cycle is a confusing area that we deal with often. A lot of times women are started on birth control pills for reasons that have nothing to do with contraception. A lot of times they're started to regulate their menstrual cycle or to help with conditions like polycystic ovary syndrome, or they stay on it and different things change on their underlying medical health and wellness. And because they're artificially getting their period every month, they're not able to use the menstrual cycle as a vital sign, as Dr. Brayboy said, to indicate if there's changes that are happening in their body that are kind of being signaled by changes in the menstrual cycle. A lot of times our menstrual cycle is a canary in the coal mine, so to speak, for other health conditions. And any change, like we were talking about, is a hint that maybe we should go to the doctor and try and get a checkup.
So if you've had, let's say, an irregular period before starting birth control, and then you've been on birth control for, say, 15 years, would that be an indication that you'd have challenges with fertility once you stop birth control?
No, we don't think that it should. If you do have challenges, it's likely that it would have happened regardless of the birth control pill. So the long-term data that we have says that it does not impact your ability to get pregnant. And I think one of the other questions that you mentioned is how long does it take for your period to come back? And that can be very variable depending on the person and the age and what their reproductive status is underlying when they come off. So it could come back the next month. It might take a couple months. And if you were irregular to begin with, it is a high chance of being irregular also when you come off.
And is there any solution once you come off, if you've been irregular, that you should really kind of look into? Dr. Brayboy, do you want to speak to that?
Yeah, so if you have irregular, unpredictable cycles and you're tracking that, you know that, that's something you should present to the office with. So, or you should have a telemedicine visit with your physician about, because essentially what that could mean, there could be some underlying issues, right? So Dr. Wolf mentioned PCOS, or polycystic ovarian syndrome. So that is very common. It's like 15% of people have PCOS, but there are other things. It could be your thyroid, right? Or it could be that you're having what we call primary ovarian insufficiency, meaning that your ovary is not acting its chronological age, meaning that your ovary is maybe not doing what it should be doing. If, let's say, if you're 32 or 28 years old, maybe it's behaving like it's closer to 40. And so that's something you want to pay attention to. And there is a lot, I wouldn't say a lot of data, but there's some good data that's recently come out. It was published in the British Medical Journal that suggests that irregular menstrual cycles is linked, essentially, that irregular menstrual cycles are linked to premature death. So, and what does that mean? So it means that individuals who don't have a typical and predictable menstrual cycle are more likely to have cardiovascular risk. And so we know that cardiovascular health in women and reproduction are linked. And so if you're having a normal menstrual cycle or a typical menstrual cycle, and you are able to track that over years, that's an indicator that you're likely in good health, right? But if something is now amiss, when you're tracking, like with Clue, you can actually show that to your physician and say, something is not normal here. I was regular, or I had predictable periods for the last decade, and something now is different. And so this motivates us to work you up and evaluate you to see what's happening.
Yeah, that's a really great point. It's definitely something not to ignore. And you touched upon this a little bit with PCOS and thyroid issues, but something like endometriosis, which is historically so hard to diagnose because many women with periods have symptoms around, with cramps and heavy bleeding, and they're just kind of chalked up to be, well, that's what it's like to have your period. But then people don't really look into it. And I myself have had silent endometriosis, which wasn't diagnosed until just recently. So how can we be more aware of these chronic issues that could eventually affect our fertility? How can we kind of advocate for ourselves? Dr. Wolf, do you want to take that?
Sure, yeah. So actually, when you're tracking is a perfect way to not just track what's happening with your menstrual cycle, but tracking other symptoms. And it may or may not be related to the menstrual cycle, but if you're tracking it in an app at the same time as your menstrual cycle, then sometimes those patterns with endometriosis can arise. And endometriosis is so difficult because depending on where it is, how severe it is, how active it is, or in what stage, or if it's the disease or the scarring that results from it, can cause a whole lot of different symptoms, and it's really difficult to piece out. But essentially, if you're having regular pain at the exact same time during the month, it doesn't really matter what time of the month it is. If it's the same time of the month, that's a clue that it could be endometriosis. And a lot of women have very long delays, just like you mentioned, women and girls in diagnosis. But if you are able to come with more specific history and say, I get right back pain on this time of the month, and I get, my shoulder hurts on this time of the month. There's a lot of signs that people don't realize could actually be due to endometriosis. So keeping them in a comprehensive tracking and symptom form is great for all healthcare providers to try and help you best.
That's very helpful. Thank you. So let's talk about reproductive aging. We see so many celebrities nowadays having kids well into their 40s somewhat effortlessly in the media and social media. Why is that, Dr. Brayboy?
Yeah, I think it's in the psyche and the perception of everyone that, I can delay having kids because, so-and-so did it, J-Lo did it, and she has twins. And, and I think that it is great that people can elect to have children whenever they want, but it's not necessarily how you think they did it. Likely at those ages, so in your late 40s and 50s, people have usually used what's called donor egg. So they've actually acquired an egg from someone who is an egg donor. And So what I want to tell people is, though, that that's not what happens naturally. So we have a trajectory, we have a reproductive lifespan, and typically your ovaries actually form when you're a fetus, if your biological sex is female. And so essentially you have ovaries that are forming while you're a fetus, and then you're born. And from the time that you're a fetus until the time that you're born to the time that you go through puberty, you are actually losing eggs. Okay, so it's like a bank account, and that's called your ovarian reserve. And your ovaries are constantly losing eggs. You're not ovulating yet. You don't start ovulating until after you go through puberty. But then once you start ovulating and go through puberty, you continuously lose eggs. And it's a process called atresia or apoptosis. And we don't know yet how to slow down that process. There's some promising research that hopefully we will one day be able to slow that process down. But it's like emptying your bank account every single month. You have an ATM withdrawal of your ovarian reserve, and there's nothing you can do to stop it. There's nothing you can do to save it at this point. And sometimes it doesn't happen in chronological fashion with our age. Again, your ovaries can sometimes behave as though they're older. The ovary is actually the first organ that ages in a woman or a person with a period. And what happens is that you essentially, you don't know, you can't predict necessarily when that will happen. But you should be aware that at 35, your risk of miscarriage goes up and your ability to conceive, your fertility decreases. So that's a very critical time. And so if you're thinking of having a child, you should really have what's called a reproductive life plan. So the United States Center for Disease Control has a very comprehensive, I want to say, workbook that really talks about what are your reproductive goals within the next year. And then from there, it really encourages you to think about, when do you want to have children? And this is something that not only people with periods should think about, but also people who have testes and have a penis, because it takes two people usually to make a child. And so if you are, whether you identify as male or female or non-binary, it really doesn't matter. Every person should really think, how do I want to have children? Do I want to have children? Do I want to conceive naturally? Do I not want to conceive naturally? What do I want to do? So that you can start having that conversation, so you don't get to your 40s and say, oh my gosh, no one told me. No one told me that there was something called reproductive aging and that I needed to make a decision early on in life. On the flip side, there are a lot of unintended pregnancies in the United States and around the world, frankly. So about 45% of all pregnancies in the United States are unplanned. And when that happens, you don't have a chance for intervention and preconception health that will optimize your pregnancy. And so the US has one of the highest maternal morbidity and mortalities of all the industrialized world because of that.
I mean, I think that's a really important point that you make. You've made a lot of important points, especially I just want to address the fact that so many women feel that it's their fault when they have a miscarriage. And, you know, the truth is, as you say, it takes two to tango. And, you know, when you do create your reproductive life plan, you shouldn't just think as a woman, or, you know, of yourself as getting tested, but with your partner is a huge
Absolutely.
factor in that too. And I think that should always be stressed, that your male partner, if it's a male, then you should have them tested too, because that takes up a lot of whether fertility will be successful or your conception will be successful. So I think that's an important point to make. So with this reproductive life plan, where could we start? Where do you start? You know, you mentioned the CDC recommendation. They have a very comprehensive workbook, but can you kind of spell that out for us?
Sure. Actually, we put in the chat the link to the workbook in case anyone's interested. But yeah, so the first thing is make a plan, right? So talk to your physician, talk to your doctor, talk to your nurse practitioner, talk to your healthcare provider about, you know, what you'd like to do within the next year. Are you planning to get pregnant in the next year? That's the question that most of your healthcare providers should be asking. And if the answer is yes, here's a great time to start tracking, especially with our app, because our app is centered on people with periods, and it's non-binary, it's you know, trans friendly. It's wonderful because there's no fluff and puff. It's just the facts, it's just science. We lead with evidence. And so you can start tracking your menses right then and there, and you will at least have that information. You can also start tracking, when you might see changes in your vaginal secretions or your cervical mucus, right? And so you can also track that. You can track actually different aspects in terms of your luteinizing hormone kit to see if you're actually ovulatory. And that's wonderful. But before you do any of that, you should really have a conversation with your doctor. Once you've had the conversation with your doctor, the other thing you should do is start taking folic acid, right? Because neural tube defects are completely preventable. And folic acid is really important in preventing those neural tube defects. And those basically are like spina bifida or other malformations of the spine. So that's something you should start taking right away. And usually you find 400 micrograms of folic acid in most of your prenatal vitamins that you can get over the counter. You don't need a prescription for them. If you have any medical problems, you should be speaking with your healthcare provider about optimizing those medical problems right away, because what happens is you start tracking, you might start trying to conceive, you might become pregnant, and you might not have optimized those medical conditions. So you're probably saying, like, what do you mean? What about diabetes, right? So there's an optimal blood sugar control before you get pregnant, because once you get pregnant, your blood sugars are harder to control. And so you want to have that control before you get pregnant, because the organs are forming. You could get pregnant and the organs are forming while you're having high blood sugars, which can lead to malformations in the fetus. Also, if you have high blood pressure, you might be taking a high blood pressure medication. And some medications are not indicated or contraindicated in pregnancy, meaning you should not take them because some of the medications can have effects on the fetus and on the pregnancy itself. So you want to make sure that your health is optimized before you get pregnant. And the other thing is, how many children do you want to have? What type of birth do you envision having? If you get pregnant with, more than one, with multiples, there are certain risks associated with that, and kind of just understanding that going into pregnancy. And what type of birth you'd like to have, because obviously there are different ways that deliveries can happen. And it's important to think about these things before you get pregnant.
Thank you. So with having said all that, should we get a fertility assessment as part of our OBGYN visit, Dr. Wolf?
So that's a really good question. And you'll hear a lot of different answers about that. And it's because of how the tests perform and what they can and they cannot do. So there's tests like anti-Müllerian hormone, a blood test, or FSH, and then there's ultrasounds that look for the small follicles called antral follicle counts. And all of these are used to look at the ovarian reserve. What they can tell you is sort of give you a gauge on how many eggs you have left in your bank account, how many have been withdrawn and how many are left. But what they are not very good at is telling you if you're infertile or if you're fertile. And that's what a lot of people are wondering. But after you think about it, a woman can be completely fertile. And to your point about the husband always needing to be an important part of that, or the partner or the sperm, that there's a lot of different things to go into whether you're fertile or not. So a woman can be completely fertile, and the sperm also actually can be completely fertile. And sometimes couples still have unexplained infertility. So it won't predict who the sperm source is, or how the sperm works, or other diseases like endometriosis. But what it does give us a really good idea about is your underlying reproductive health. So I think it's really important for all women to get a baseline when they're young, maybe 20 years old, go in for an evaluation, learn about your reproductive health, show them how your periods are, what their cycles are like. And then we have baseline levels that do tell us a lot about reproductive diseases like primary ovarian insufficiency and polycystic ovary syndrome. So I think they're really good screening tests for conditions associated with reproductive disorders.
So, having said that about your AMH level and it kind of giving you this snapshot of where you are in your fertility at that moment, a lot of people think, okay, maybe I should move quicker into my reproductive life plan if I want to get pregnant, or maybe I have some more time on my timeline. So those who kind of feel like they want to move faster, and let's say they don't have a partner, when do you think that fertility preservation, aka egg freezing, should happen? At what age is most ideal?
That's a really good question. It's hard to have a blanket statement because really it's best as a conversation with each person and what their goals are, when they want to have children. The downside of freezing too young is that many women wouldn't need those eggs, or they wouldn't come back and they wouldn't use them because they either got pregnant on their own, or they decided to have children in another way, or not pursue parenthood, any of the above.
And it's expensive.
And it's expensive. And it doesn't guarantee you that you're definitely going to have a child. So just because you have 15 eggs in the freezer doesn't mean that that's going to give you a family of 4. So it depends on
that.
I mean, often patients have to go through more than one cycle just to have one baby. So it's not uncommon, if you think of it in that terms, that if you just did one cycle of egg freezing, that it would be similar, that not everyone's going to get a baby from that one cycle of egg freezing. The hard part is that when you're youngest, those eggs work the best and they have the highest chances of making babies that are born. The downside is that you may not ever need it or have needed it. As you get older, that risk benefit and calculation kind of changes. So if you're getting close to 30s, mid 30s, or you're in a point in your life when you know that you can't have children until after a certain age, like 38, 40, then I think it becomes way more important to freeze not only oocytes, but embryos if you have a sperm source that you want to fertilize with.
And can you quickly just distinguish the difference between freezing eggs and embryos and the limitations of testing when you freeze your eggs?
Yes. So when you freeze eggs, that's the very first step of in vitro fertilization. And we take the eggs out and we take them to the laboratory and they count them, but they can't really say if they're healthy or unhealthy, or if they're going to fertilize. And during IVF, for instance, if a patient goes all the way through IVF, if they get 20 eggs at the beginning, that's great. But not all of the eggs are usually mature and able to be used. So let's say maybe only 17 of those eggs end up being mature and are able to be attempted to be fertilized. So then also all of the mature eggs aren't able to fertilize. So then it drops down a little bit more. So maybe you only have 12 eggs that fertilize normally. And then that's just the second day. And you watch them in the IVF laboratory to see how they grow. And the majority of those stop growing and die in culture because they're not destined to be able to have create a human pregnancy. And human reproduction is really inefficient. That happens all the time, even with spontaneous conceptions. So if you freeze eggs, you're not going to know how many are going to fertilize, how many are going to grow, and how many are going to be able to make it to the blastocyst stage. And what you can do at the blastocyst stage is testing on the embryo to look for diseases like Down syndrome or sickle cell disease or cystic fibrosis or other monogenic disorders. So the good part about freezing embryos is that you'll know better if you're able to make blastocysts well or not well. And sometimes that tells you how many cycles that you would need to do total. But if you don't have a partner, then you're not able to use those eggs down the road with a future partner sperm.
Right. So egg quality and sperm quality is obviously very important when creating embryos, especially in a lab. So if you had to prioritize, what would you recommend as actionable things that we can start doing right away to optimize our fertility, no matter gender?
So eating healthy, watching simple sugars, going in for a reproductive evaluation and there's blood tests that we can see if your immunizations are still protecting you, that can prevent you from having viruses that cause birth defects and pregnancy complications. Limiting alcohol intake and drugs like marijuana, decreasing excessive caffeine use, a little bit's probably fine. and just trying to really focus on a healthy lifestyle and really tuning up anything that may, have slipped recently.
Great. So let's talk about infertility and when we should seek treatment. So Dr. Brayboy, can you define infertility for us?
Sure. Actually, infertility has two definitions. So if you're under 35, it's 12 months of trying to conceive without being able to conceive, and that could mean intercourse, or that could mean donor inseminations. And then if you're over 35, we don't wait that long because age is everything in fertility. So it's 6 months of trying to conceive. So if you meet those definitions already, you should already be seeking assistance if you're interested in becoming pregnant, because usually people conceive within the first 3 months. And if you don't conceive within those first 3 months, you should start thinking, what's happening? You can actually track when you're having sex in the Clue app, and you can track that as it relates to your cycle, so that when you're trying to conceive, you can sort of understand, I've been trying to do this now for 3 months, and you can communicate a history like that. So your doctor might sort of say, okay, well, if you're over 35, let's wait a couple more months. And if you still don't get pregnant, then you should be referred to an infertility specialist like Dr. Wolf or other people who are board certified in reproductive endocrinology and infertility. And the reason being is because the more you delay, the longer it takes to get your evaluation and then have a treatment plan. So really, when you're tracking and understanding, like, I know that I think that this is the time that I'm conceiving, or this is the time that I'm trying to conceive, this is when I'm having sex, these are my cycles. The more information you can convey, the easier it is for the doctor or your healthcare provider to understand what's happening within the context, to do an evaluation, and then have a plan for you, because everyone's plan will be slightly different depending on the diagnoses.
And if you are over the age of 35, are there any circumstances in which you would recommend seeing a fertility specialist right away?
Yeah, for me, I think if you already have been diagnosed with something like endometriosis or hypothyroidism or hyperthyroidism, or you have, you've had perhaps, let's say, in the past, maybe several miscarriages, this is the time when you want to present, because there could be something else happening. There could be something else going on. Also, if you have any chronic medical problems, so if you have any conditions, you really want to present earlier rather than later. And that's because we might need to have you go to a maternal fetal medicine specialist, and that's an OBGYN who is specifically specialized in managing medical problems during pregnancy. And the reason we want you to go before you get pregnant is so you understand what the risks and the benefits could be. And there are some risks associated with some chronic medical conditions. And it's really also very important to give a good history, not only of your menstrual cycles through tracking, but also of your family. So a family history is super important. And oftentimes patients don't understand, why do I need to tell you all of my business? But really, it's important that you know at least back to your grandparents and all of your aunts and uncles and cousins, if they've had any issues, and not just reproductive issues, but any diagnoses. For instance, if you had, let's say, two maternal aunts, that would be two sisters of your mother, who had early breast cancer in their 30s. That's significant. We want to know about that, because as Dr. Wolf said, if there are any family histories, we might want to offer genetic testing for embryos if you end up going through IVF. Even if you don't end up going through in vitro fertilization, you might want to speak with a genetic counselor, because a genetic counselor can tell you your overall risk. And so oftentimes we'll ask patients, what is your ethnicity? That also helps us to understand what your risks for certain genetic diseases are. As Dr. Wolf mentioned, sickle cell. So it's really important. Cystic fibrosis, there are many, different diseases and different ethnicities. It's really important to kind of be able to capture that history. This is, I think, something that maybe the general public doesn't know, and I think it's really important to maybe have a conversation. Also, at Clue, what we try to do is not have the stigma that surrounds people with periods, right? We try to normalize menses, we try to normalize issues with periods, and we try to normalize also infertility, because infertility, frankly, affects 1 in 8 people in the United States. And ESHRA has some data that it affects 1 in 6 couples around the world. And so it's very common. And the more you don't speak about it, the more people feel isolated in that, oh, it's only happening to them, or it's something that I did, or it's my fault. And again, it's not the case. A third of the time it is female factor, but a third of the time it's male factor, and a third of the time it's because there's a male and female factor, and it's usually unexplained, which just means we don't have enough research yet. And that's hopefully changing with more and more people hopefully going into the sciences and hopefully studying reproductive biology.
Absolutely. So in choosing a fertility specialist or clinic, what are the important factors to consider, Dr. Wolf?
So it's interesting because as a doctor, I'm going to say that one of the most important things is not the doctor. It's actually the IVF laboratory. And that's everyone behind the scenes, the embryologists that handle the eggs and the sperm and keep the incubators at exactly the right temperature and make sure the media and everything is pristine and precise and very well controlled. And that really has the biggest impact on pregnancy rates and success rates in general in IVF. And then beyond that, if you came to Pelex, we could talk to you about what your goals are, what you like in a physician, what you would like to avoid if possible. And I think matching personalities is a really important thing, that you have the right fit. Some patients like a lot of information. They want details, give it to me all. I'm going to process it. I'm going to write it all down. Other patients don't want a lot of information. It stresses them out. Just tell me what I'm supposed to do and I'll go do it. So I think there's different fits for different people, and bigger practices versus smaller practices, and there's pros and cons of both. But it's really a lot of personal important factors that go into choosing, but most importantly, it's the lab and the success rates. And one of the ways you can tell what a IVF lab success rates is to go to SART, S-A-R-T. It's a law that all IVF clinics need to report what their success rates are. So you can check any prospective clinic that you're considering to see how well they do with their pregnancy rates and their treatments.
That's very important to know. SART is actually an excellent resource, but I know a lot of people kind of have a hard time navigating those success rates. Is there any kind of easy way to do that on the SART website?
Yeah, it's not an ideal website for sure. But there's a page that if you can eventually get to, that you can put in your age and your height and weight and diagnosis and check after 1 cycle or 3 cycles what the success rates are. And again, that's other types of counseling that I think is really great to have with a provider. And as a telehealth provider, we can do that for people no matter where they are.
Great. And we will definitely share the website in the chat. So also, can you tell us how much does previous experience trying to conceive inform secondary experience? So if you've gotten pregnant very easily and you've had your first child, how does that kind of inform you trying again for your second or third?
We tend to think that whatever happened with our first and second is probably going to happen with our third. And then when it doesn't happen, it's often another one of those surprises in life. But it's not uncommon. Secondary infertility is actually very common. So people can have no problem getting pregnant with their first or second or however many pregnancies, and then later they do have an issue. I think the more that you understand about reproduction in general, the better informed you are as a patient and a consumer of even reproductive services or even gynecological or obstetrical. But there's a huge learning curve that goes into IVF. It's very time constrained. It's very complicated. The technology changes very quickly, and you can't even rely on maybe your sister or your cousin or your aunt or your friend who went through 5 years ago, because things have changed so much. So when in doubt, you could always get second opinions to see if what you're being told by one provider agrees with a second provider.
And how would you know what kind of treatment is right for you? Let's say, you're offered to start with an IUI, or should you just go straight into IVF? How do you know that?
It's a difficult question. And sometimes it comes down to cost. Sometimes it comes down to how long you're willing to try. And so for instance, a common pathway is, well, let's try IUI 3 to 6 times. And then if you're not successful, come back and we'll start IVF. But if you're 38, that might take a full year or a year and a half in a pandemic. And then now you're 39 and the success rates go down. So I encourage patients to move to IVF more quickly when they're later on in their reproductive years. But another thing that I think people don't realize when they're just starting out is how difficult the IVF and infertility treatment can be. You know, usually these couples and women have tried to get pregnant for a long time and been disappointed with a lot of months of negative pregnancy tests. And so all of that creates an emotional burden. And then they finally decide to make an appointment with the infertility doctor. And they say, okay, well, I'm sure, you know, it's fine. And we're going to get pregnant right away. And then like, but I really didn't want to do an IUI. And then they have to like decide to do an IUI. And then but I'm sure it's going to get pregnant. I'm sure it's going to work with the IUI. And it's this process of all these little compromises that patients have to make, and the stress is significant and it accumulates and it's not easy. So one of the things that I try and educate when patients are deciding what treatment is best for them is to give them the long view and let them know, hey, you know, you're 35, you've been trying for 4 years. How many kids do you want? You know, this is all hard. You might have a miscarriage in between, or, you know, a delay because of a polyp or an ovarian cyst. And all of those are big disappointments. So I think there is something to be said for if you're amenable to IVF, to doing it earlier rather than later. Just because you can freeze those embryos and use them for your second or third or subsequent pregnancies.
Great. Thank you, Dr. Wolf. Thank you, Dr. Brayboy. Okay, I want to get into audience questions while we still have time. So I'm just going to jump right in. Somebody asked, is it normal to bleed a little several days after your period? I tend to get small blood along with discharge. Either one of you can take it.
I'm not sure what small blood is, but I think maybe spotting is what they're referring to. And again, this is not medical advice. So this is just an informational webinar. So I can't give personalized medical advice. But when you are tracking, you can actually start to see, is this what always happens or is this new for you? And that's the major difference, right? So if you have bleeding, let's say for 3 days, that's like heavy, you have to wear tampons and a pad. And then let's say you just have very light bleeding and you only need a panty liner. That's typical. That's a typical menstrual period, right? But if you have, let's say, bleeding that stops, you have maybe a little spotting, and then let's say you have spotting after intercourse, that's a red flag for an OBGYN. We might have to evaluate, is there something on your cervix that's causing that, like a cervical lesion, like a polyp, an ulceration? Could it be cervical cancer? This is why tracking is important, because you shouldn't really have any bleeding in the menstrual cycle except during your menses, except during the period. So if you're having this, like what we used to call intermenstrual, spotting, or postcoital, meaning after sex spotting, that's not normal, and you should present to your physician and have a discussion about why that's happening.
Hello from Norway. What are the odds of having a healthy baby after the age of 44? Dr. Wolf?
So healthy is very subjective. And there's no way to know for sure that even if you have a healthy pregnancy, that something unexpected like childhood cancer could occur. But usually what we look at when we answer questions like that is the chances of having a full-term birth of a baby that is healthy when they're first born. And it is low with spontaneous pregnancy after 44, and it's not very easy to get pregnant with IVF either. But it does occur. So pregnancies can occur all the way up until menopause. It's just that they occur at a much lower rate. And the chances of chromosome problems like Down syndrome go up dramatically after 40. So it's about 1 in 40 pregnancies that have Down syndrome after 40, and increases even beyond there if you're 44.
What is the relationship between stress and menstrual cycles?
Yeah, so a lot of people think that stress doesn't have an impact, but it does actually. So the hypothalamus, which is sort of like the central command center in our brains for our menses, can be impacted by stress. So if there's famine, let's say, and you don't have access to food, your menses could stop, and that's called amenorrhea. Let's say you are training, you're an athlete, and you are doing, marathon training, or you're a skier, and you're training so hard, and you're not able to meet the caloric needs of the training schedule that you're keeping, then potentially your menses could become irregular or stop altogether. And so stress definitely plays a role. There's not any data yet from the pandemic, but I'm sure eventually we'll see from this pandemic that there's going to be a lot of stress that people have been under, and that probably has an impact on menses. And so stress, emotional, duress, that can definitely have an impact on menses.
My partner has a minimum count as well as a low motility rate. What can be done?
I'll take that one. So sperm testing is also fraught. We talked about the issues with ovarian reserve testing, and unsurprising, because you only need one sperm to fertilize. It's very difficult fertilize an egg and make a pregnancy. It's very difficult to study individual sperm and what they have and correlate with what will happen. So when men get a sperm test, a semen analysis, if they have just one category that's abnormal, it's less likely that they're going to have trouble getting pregnant. But if they have more than one abnormality in 2 different categories, that is more likely to indicate that there would be a male factor problem. But even within any of this testing, there's a wide curve, and some people with really great scores are completely infertile. We don't understand why. And some people with low scores or tests are able to get pregnant just fine. But the chances for infertility go up when there is a problem or more than one problem, and the chances that they're more fertile are better when the testing is reassuring. So if they have a problem with 2 different aspects of the semen analysis, one of the first things that is often recommended is ovulation induction, meaning a pill. The female partner takes a pill and they undergo intrauterine insemination. And usually that is the recommended treatment for isolated male factor infertility.
There's an interesting question. Lowering marijuana use was mentioned. Has marijuana been shown to affect fertility?
So according to guidelines that Dr. Wolf and I subscribe to, yes, basically we do think that there's some impact on sperm motility. We do think there's some impact on perhaps even ovarian function. And really the problem is with marijuana that you don't know where you're getting it from often, and there could be added chemicals. And so people may not realize that the ovary is extremely sensitive to toxicants, and so would not recommend it, especially when you're trying to get pregnant. That's my opinion.
Great. What about small size fibroids? How do they affect fertility?
Great question. So the thing about fibroids is the most important factor is where they are. So if they are on the top and they kind of just sit almost on the outside of the uterus, those don't usually affect infertility. We don't think that that's a significant contributor. If the fibroid is very close to the lining on the inside of the uterus where the endometrium is and the embryo wants to implant, those type of fibroids can impact fertility. And we actually do recommend surgery to remove those before infertility treatments to prevent difficulties with implantation or early pregnancy loss or pregnancy complications.
Oh, somebody just asked, what is a fibroid?
Oh, okay. A fibroid is a benign tumor of the muscle part of the uterus. So the uterus on the outside has muscle, and on the inside has glands and tissue to hold it all together, stroma. And a fibroid is the muscle cell that starts dividing, and it divides and divides and divides, and makes a hard white ball that's like tough, hard tissue. And very common in women. And when we get up into our 70s, 70% of us, 70 or 80% of us will have at least a fibroid, and they're really prominent in the African American community, and can present much earlier and more severe.
I want to ask this question because we talked about this a little bit. Is a higher than normal AMH level as you approach 35 reason for optimism when trying to conceive?
So the AMH is a tricky one because it's a little bit like Goldilocks. You want it to be not too high and not too low. And one of the studies that people cite as evidence for not using it to test for an infertility test is when they looked at a group of women for 12 months, the ones with low AMH, which we would typically think had lower ovarian reserve and it would be harder for them to get pregnant, actually got pregnant, as well as people with normal AMH. But the patients who had even slightly high AMH, they had actually a lower pregnancy rate. So it depends on how higher than average is. If it's above 10, then we really think strongly that there could be polycystic ovarian syndrome underlying whatever their reproductive status is. But again, one of the reasons that we can't really say whether a perfectly normal AMH is reassuring or not reassuring for fertility is because it's not very good at predicting who's able to get pregnant and who's able to not get pregnant. So some people say that they would recommend to not even test them at all, but I would say that the AMH being normal is reassuring that there isn't severe PCOS and that you don't have POI right now, and your ovaries are still functioning, and have a good amount of ovarian reserve.
Great. I want to ask this question because I think it's very important to address. Can previous abortions lower fertility? Dr. Brayboy?
No, they can't. I think a lot of people are very concerned because that's what they've been told. So no, having an abortion in and of itself does not lower your fertility. And there's different modalities for abortion. We actually have an article about this on helloclue.com that is free. So you can have medical abortion or surgical abortion. There can be some complications with surgical abortion where you can get some scar tissue if the surgical technique was too vigorous, but that's very, very rare. That's called Asherman syndrome, and you can get some scar tissue, but it's not something that we see on a routine basis. And so most people, when they have a termination, as long as they haven't had an infection or anything afterwards, do quite well and are able to conceive because it doesn't impact your ovarian reserve. It's something that's localized to the uterus. And if you've been pregnant before, make sure that you disclose that to your physician, because it's very different when someone says, I conceived and, I had a termination versus someone who's never conceived. It gives us an idea of you have secondary infertility versus primary infertility. And it's okay to disclose it. I think what we should realize is that 1 in 4 people have a termination by the time they turn 45. And it's also very normal to have an unintended pregnancy. It's not ideal for a lot of women because they have to make that hard decision, but it is common. And so you shouldn't feel any guilt or shame over having had a termination.
Great. I am 28. My husband and I have been trying for 11 months now. My doctor doesn't want to test any levels or do any blood work until we've been unsuccessful for a full year. So how do we advocate for ourselves in these situations?
I think that that's a common problem, and the doctor is following the guidelines, and the guidelines say just go and try for 12 months. But for me in Pelex, I think it's silly to say in this day and age when testing is so cheap to have a couple be unsuccessful for 12 months if there's no sperm. So there's at-home sperm testing kits. This is a femtech and fertility talk. There's a lot of direct-to-consumer ways that you can check things now, and the costs have come down a lot since some of those recommendations were made. But again, one reason why they don't recommend testing is because it can't, the ovarian reserve test can't tell you if you're fertile, can't tell you if the sperm's normal, can't tell you if the sperm's there. But it can tell you about other health conditions. And I think, if you made an appointment with Pelex, we would be happy to order testing and understand more about your reproductive function, and do sperm testing either through regular clinic, laboratory clinics, or direct to consumer that you can order on the internet.
Great. I think this is a good question. What are the rates of miscarriage in spontaneous pregnancy versus IVF pregnancy? I know this depends on age too, but can we talk about that?
I'll let Dr. Wolf take this one.
So the thing, human pregnancy and reproduction is very inefficient. And we think that up to 30% or even more actually end in miscarriage, and most women never realize that they were pregnant at all. So the difference, there's a big difference between spontaneous pregnancy and IVF pregnancy in the amount of watching and measuring that IVF pregnancies or fertility pregnancies after IUI get compared to the normal woman who gets pregnant. So if a woman without infertility becomes pregnant, she calls her GYN, they say, great, I'll see you in 2.5 months. And there's nothing that's tested typically if she doesn't have any problem. So it's hard to know how many of those pregnancies sometimes end in miscarriage. But with IVF, because we're following them so much more closely, then we pick them up more often. But they're also an infertile population to begin with, typically, and so miscarriage rates can be higher. They also can be older, and the miscarriage rates as you get closer to 40 after an IVF pregnancy are pretty high. Even unfortunately, if you see a heartbeat, which is usually a pretty good sign in a non-fertility patient. So they're definitely high for multiple reasons in IVF rather than spontaneous pregnancy.
And I just want to add one caveat to that, was that through Clue Plus, you can actually track your pregnancy. And so it's a new feature that we have. And actually, we have a 7-day free trial. And the really important thing about Clue and Clue Plus is that you know your last menstrual period. So we're able to date the pregnancy. And that is so important when we're trying to establish viability, which Dr. Wolf just said, which is a heartbeat, right? So is this a viable pregnancy? Does it have a heartbeat? Is it growing as it should be? If you don't know when your last menstrual period is and you get pregnant spontaneously, it's guesswork, right? And so, a lot of people might say, oh, come back in a week, maybe your dates were off. Oh, come back in 2 weeks, maybe your dates were off. And if it is a non-viable pregnancy or miscarriage, that just prolongs the anxiety for you, for your family. And so it's much better to know exactly when your last menstrual period is, and then to track. In our tracking feature, we also have articles written by nurse midwives and physicians, fact-checked by physicians, about what you should expect at every single week of your pregnancy. And if there's any spotting, any cramping, these are things that you can track and bring to your physician or call before your appointment, because as Dr. Wolf said, often you won't get an appointment for the first couple months. It takes a while to get in to see an OBGYN. But if you're having issues, you should present earlier, because it could signal something else is happening.
How do we help people who are not able to have kids to accept and live with it? I think that's a really important question to answer.
Yeah, I'll say that one. It is not always the case that you might be able to have a biological child. And a lot of people feel as though there's some failure associated with that. There is not. I think that people don't realize that there are other ways of becoming a parent, or you could elect to not have children at all. So one of the other ways, as we mentioned a little bit before, is with donor egg. One of the other ways is potentially with donated embryo. And another way is to adopt. And there are all different ways to become a parent. And it doesn't change your relationship, your bond with your child, if they're biological or if they're adopted, whether they be adopted egg, adopted embryo, or adopted child. And so I will tell you, as the granddaughter of someone who adopted a child who was infertile, my mother was adopted. I am grateful that adoption exists, because I wouldn't be here giving you this webinar had we not been adopted. And we had a very good life because of her willingness to take in someone else's child. And then she spontaneously conceived my uncle.
It's amazing.
It is.
Well, we have so many questions we didn't get to, but I think we're kind of at the line. Maybe, can we do one more?
Yeah, we can do one more.
Okay. Do fertility supplements actually help with fertility? Who wants to take that?
I'll let Dr. Wolf take that one.
Okay. So fertility supplements, that's a kind of a really broad category. There's ones that are marketed towards men and some that are marketed towards women. The supplements that are most important are folic acid, making sure that your iron levels are healthy and normal, and getting this is part of what we look at if you come in for a preconception evaluation, is to look at some of the things that might be deficient, B vitamins, etc. And then it's also important to make sure you're eating a balanced diet. There's a lot of literature out there about other supplements like DHEA or CoQ10, and while there's emerging evidence that there might be a benefit in some situations, from our side as medical practitioners, we sort of usually wait until there's a study, a human study, that shows that it improves pregnancy. So there have been some supplements that have been shown to improve markers that are associated with better for pregnancy, but not actually the pregnancy itself. But a lot of these supplements, as long as they're not contaminated and they're from a good source, they're not contaminated with other toxicants or elements, then they're probably safe. But as supplements, that means that they're not regulated by the FDA, so it's difficult to know what the quality is. Sometimes what they say they are they're not even what they say they are when they're tested. So there is better evidence with some of the male fertility supplements, but you have to make sure that you're taking the right kind, that it isn't going to decrease sperm production if you're taking a men's health supplement. So it's difficult, and it depends on what type of supplement we're talking about.
Okay, thank you. That was terrific. We had so many unanswered questions today, but for those of you who did submit a question, they weren't answered, please refer to pelexmed.com, where you can book an appointment and speak with Dr. Wolf. So I just want to say thank you for joining us tonight and for being open to these very important conversations and being part of this community. We hope you found this very helpful. And a huge, huge thank you to our co-hosts, Dr. Brayboy and Dr. Wolf, for their insights and support and for bringing us together tonight. We can't say enough about how much we love your philosophy. If you want to learn more about us, please check out the Clue app. I know in the chat, Dr. Brayboy and Dr. Wolf and I have all left our websites and Instagram accounts and other resources for you to benefit from. And a final note is that everyone who attended today's event will receive a follow-up, so please be on the lookout for those emails. And thank you again, everyone.
Thank you for having us. This has been a pleasure, and hopefully you've had some of your questions answered. And if you want more information about your overall reproductive health, check us out at helloclue.com. And also we have a free podcast on your favorite podcast host. It's called Hormonal, and you can learn more about hormones and your fertility there.
Excellent. And also thank you from Pelex and everyone that has registered. We're offering a free 15-minute consultation. So contact us on the web or the information in the chat, and we look forward to helping you. And big thanks to KORÄ for sponsoring and Diana for moderating. Really great job. Really appreciate it.
Thank you. It was such a pleasure.
Bye.
Bye.